The FEBerry Training Institute present status neutral navigation. We have some learning objectives. At the end of these presentations, participants will be able to comment on undetectable equals untransmittable concept, list at least one pre-exposure prophylaxis medication, and elaborate on status neutral navigation outcomes. I have a couple of questions or concepts that I'd like to review with you. So in your own words, what is PrEP? Could you put it in the chat room? It will be interesting to see our concepts before we start with the presentation. In your own words, what is art? Again, if you want to write some of your comments or your answers on the chat box, that would be fantastic. What is health literacy? Tell me about HIV test. And what is status neutral navigation? Let's start with another concept that is pretty much applicable and very important for this presentation, health literacy. Health literacy is defined as a cultural, cognitive, and social skill, which determines the motivation and ability of individuals to gain access to, understand, and use health information. Scholars describe poor health literacy as the silent epidemic, which is challenging for the function of the health care systems all over the world. Low health literacy has been associated with inadequate management of long-term conditions. Health literacy has been an overlooked factor when dealing with HIV. Persons with low health literacy were more likely to miss treatment doses because the confusion, the depression, the desire to cleanse their bodies, that some participants that they have higher health literacy skills can understand easy some health-related concepts. Poor health literacy creates barriers to fully understanding one's health, illness, and treatments. Misperception of treatment in the case of HIV infection creates danger for potentially transmitting treatment-resistant strains of HIV. Poor health literacy is a barrier to access the healthcare services for patients living with HIV. Tailored interventions should be aimed at enhancing the health literacy skills of patients affected by HIV infections to improve their ability to navigate the health system. Enhancing health literacy can improve understanding of HIV diagnosis, treatment adherence, the health-related behaviors that we always talk about, and some of them are stigma and self-stigma, and health outcomes, CD4 count, viral load, and hospitalization. All of these concepts are pretty much linked to the health literacy skill levels of the population. Health literacy is very low. People with health literacy skills have serious problems understanding either viral loads and don't fully understand preventive issues. And as you can see in this slide, they are highlighting some of these discrepancies, but low health literacy is key in understanding HIV/AIDS. Let's talk about testing. Again, how many of you work in outreach and testing campaigns? Let us know. Let's type something over there so we can have a better understanding of the group. Can you mention some of the HIV tests we currently use? Again, we're going to be reviewing your answers in the chat box. So let's have an overview of the HIV testing. HIV test is the only way actually for us to know our HIV status. There are free or low-cost tests available, and for people that they is 12 and older, regardless of their immigration status. People really doesn't need a consent form or parents or guardians' approval to get tested. In the different kind of tests that we have for diagnosis, there are some that they are just looking for the virus, the NATS, which is the nucleic acid test, viral load. This test is just looking for the virus in blood. When we're talking about the antigen antibody tests, look for both the HIV antibodies and the antigens, as their name. And remembering antigens are foreign substances that cause your immune system to activate. If infected with HIV, an antigen called P24 is produced even before antibodies develop. There is also a rapid antigen antibody test available. Antibody tests detect the presence of antibodies, which mean the proteins that a person's body makes against HIV, not HIV itself. Most rapid tests and home tests are antibody tests. Then looking into the different types of HIV tests, there are the standard laboratory blood tests that are very accurate and provide results within a few days. The finger stick blood test provide results in 20 minutes or less. The oral swab test, that doesn't require giving blood and provide results in about 20 minutes. The home test kits are available for purchase. They can be used as oral swab and allowed to test in the privacy of your own home. The non-clinical settings typically provide the same day kind of rapid testing and they may offer HIV prevention services. Results of rapid tests are often provided in less than 1 hour. The test may be called rapid HIV testing or CLIA wave rapid HIV testing. Rapid HIV test specimen collection at the testing site could be via venipuncture, which is blood drawn from your veins, finger sticks, or oral fluid. A little bit of the CLIA certificate, which probably is interesting to remember. And the CLIA Laboratories Improvement and amended in 1988 established kind of a quality standard for any laboratory test to ensure their accuracy and reliability and timeliness of the results. CLIA requires that any facility examining human specimens for diagnosis, prevention, treatment of a disease may register with the Center for Medicare and Medicaid Services, CMS, and obtain a CLIA certification. The Food and Drug Administration, FDA, has approved several rapid HIV tests as wave tests under CLIA. We have several generations of tests. So the third generation rapid tests are OraQuick, advanced rapid HIV test antibodies, and whole blood, plasma, or oral fluid. Reveal, rapid HIV antibody test in serum or plasma. The Unigo, recombined HIV test, whole blood, serum, and plasma. Multi-stop HIV 1, HIV 2 rapid test is in serum and plasma as well. And then we have the NC HIV 1 antibody test. Now we go to the fourth generation rapid test. And the fourth generation rapid tests are the earlier determinant HIV, have AB combo test that can be done in blood, serum, or plasma. The ClearView have AGAB stat pack, same thing in whole blood, serum, and plasma. And the ClearView complete HIV have in whole blood, serum, and plasma as well. Home tests, you probably know about home tests that are in use for several years. We have the Home Access HIV-1 test system, drops of blood on a card that gets mailed to the lab. And the other quick in-home HIV test, oral fluid test for home, and the results can take as little as 20 minutes. HIV home tests, some of non-clinical testing sites engage in this testing type with their clients. The issue of these non-clinical HIV testing sites is that they can be available for follow-up counseling, and but actually they can distribute the test over their sites and serving as the resources for clients, helping them to interpret their results. Two home HIV tests available in the market are like the Home Access HIV-1 test system, where a self-collected sample is mailed to a lab for testing, and the OraQuick in-home HIV test. These tests can be purchased online and in stores. Let's talk a little bit about the HIV false positive results, and then we are going to address a little bit about the false negative results. False positive results is when a person is not infected with HIV, but receives a positive test results. Generally, HIV tests have a higher specificity, meaning that there are few false positive results. If 1,000 uninfected people are tested with an HIV test and 4 have false positive results, the HIV test specificity is 99.6%, which is a very good test. The causes of false positive HIV test results can occur due to technical issues or biological causes. Biological causes include the participation maybe in an HIV vaccine study, an autoimmune disorder, and the medical conditions that may have. Continue with the false positive test. Some reasons for a false positive test, as we mentioned, which is the antibody-based test in this case, it can be lab error, it can happen. Cross-reaching antibodies, autoimmunity, HIV drug use, multiple pregnancies, recent immunization, chronic alcohol use, and cirrhosis of the liver. HIV false negative results. People infected with HIV will develop HIV antibodies in their bloodstream within 3 to 6 months of the infection. People infected with the virus during the 6 months prior to ELISA HIV positive test may have a false negative test if they are in this window. The test may be reported as negative, but the person may be infected because the body may not yet have produced enough antibodies to be detected by the test. To be sure, the person must be retested at least after 6 months. False negative and positive test. In a summary, a false negative result may be coming from this window period, and gamma-globulinaemia, seroconversion, the loss of HIV antibodies due to extreme immune system disruption when we are in the late phase of the disease, technical error, or type N or O strains of HIV-2. False positive results may come from an antibodies, example SLE, HIV vaccines, or technical error. Let's talk about U equal U. I know that is a very common term now for us, and let's see how that started. Going HIV is today, not what it used to be 30 years ago. HIV is described as a chronic, manageable disease. HIV prevention is not what we used to have before either. The simultaneous use of the undetectable equals untransmittable and the pre-exposure prophylaxis causes a radical change in the way we talk about HIV transmission and prevention. So U equals U. And to talk about a little bit about the U equals U is that an overwhelming body of clinical evidence has established that HIV undetectable is untransmittable. It's that people living with HIV who achieve this mean undetectable viral load, so the amount of HIV virus in their blood, by taking and adhering to antiretroviral therapy, ART, as prescribed, cannot sexually transmit the virus to others. HIV medication is called, well, antiretroviral therapy or ART. The HIV medication reduces the amount of HIV in the blood, which is the viral load, taken to the very low level, which keeps the immune system working and preventing illnesses. This is called viral suppression, defined as having less than 200 copies of HIV per millimeter of blood. HIV medication can make the viral load so low that a test cannot detect it. This is called undetectable viral load. And HIV untransmittable. Other benefit of reducing the amount of virus in the body is that it helps prevent transmission to others through either sex, syringe sharings, or from mother to child during pregnancy, birth, and breastfeeding. This is sometimes referred to as treatment as prevention, or undetectable equal untransmittable. And as you can see here, a person living with HIV who has an undetectable viral load does not transmit the virus to their partners. Let's talk a little bit about the pre-exposure prophylaxis for HIV protection. Pre-exposure prophylaxis, people who are getting in the risk of getting HIV and take HIV medication every day, reduce the chances of an HIV infection. 2 HIV medications are approved by the US Food and Drug Administration, the FDA, to use as pre-exposure prophylaxis: the tenofovir, miraxibine, TDF-FTC, and other combinations of the tenofovir known as the TAF-FTC. And PrEP is most effective when taken consistently every day. CDC reports that consistent use of pre-exposure prophylaxis reduce the risk of getting HIV from sex by about 99%, and from the injection drug use at least 74%. Who should consider taking pre-exposure prophylaxis? Well, pre-exposure prophylaxis is for people who do not have HIV infection, but are getting or can potentially get HIV infection through sex or injection drug use. CDC recommends pre-exposure prophylaxis for people who are HIV negative, who have had anal or vaginal sex in the past 6 months, and have a sexual partner with HIV, especially if the partner has an unknown or detectable viral load, or have no consistent use of condoms, or have been diagnosed with a sexual transmitted disease in the past 6 months. Again, let's continue talking about who should consider taking part. PrEP is also recommended for people who inject drugs, have an injection partner with HIV, or share needles, syringe, or other equipment for injecting drugs. Pre-exposure prophylaxis should also be considered for people who have been prescribed non-occupational post-exposure prophylaxis and report continued risking behaviors or have used multiple courses of post-exposure prophylaxis. Thus, pre-exposure prophylaxis causes some side effects. Yes, in some people, pre-exposure prophylaxis can cause some side effects as nauseous. These side effects are not serious and generally go away over time. If you're taking pre-exposure prophylaxis, tell your healthcare provider if you have any side effects that bothers you or that doesn't go away. Pre-exposure prophylaxis and the use by race and ethnicity. So we know that there are so many disparities in health when we're talking about race and ethnicity. And now we can see in this graphic the same issue. In white population, the use of pre-exposure prophylaxis is way higher than in minority groups. On the other hand, when we compare male and female, I think the use by the male population is overwhelmingly high than in the female population. So if we're looking into Black and Hispanic MSMs, were significantly less likely than white MSM to be aware of pre-exposure prophylaxis, to have discussed with the healthcare provider or have used pre-exposure prophylaxis within the past year. Among those who had already addressed this issue of pre-exposure prophylaxis with a healthcare provider, 68% of white MSM, 62% of Hispanic MSM, and only 55% of Black MSM reported pre-exposure prophylaxis use. These disparities along the HIV pre-exposure prophylaxis continuum of care among Black, Hispanic, and white MSM emerge as the point of discussion with the healthcare provider. There are not enough providers talking about that, or when they are addressing the issue, perhaps it's not with the kind of cultural approach that minority groups need to have to understand exactly the benefits of a pre-exposure prophylaxis. Let's talk a little bit about the antiretroviral therapy. And very simple, reduces kind of the HIV in the virus and the risk of transmissions. It's going to help prevent HIV from advancing to become AIDS and actually protect the immune system. So let's talk a little bit about that. What is ART medication? Treatment involves taking medication to stop the progression of the virus in the body. HIV is a type of virus called a retrovirus, and the combination of drugs used to treat it are called antiretroviral therapy, or ART. ART is recommended for all people living with HIV, regardless of how long they have had the virus or how healthy they are. Why is it important to be in treatment for HIV? Getting and starting an HIV treatment reduces the amount of HIV in blood to a very low level, and that is the viral load that we have been talking about. It keeps people living with HIV healthy and prevent illnesses. And there is also a major prevention benefit called treatment as prevention. People living with HIV who take HIV medication daily and keep an undetectable viral load have no risk of sexually transmitting HIV to their HIV negative partners. Antiretroviral therapy or ART can, yes, cause some side effects. Not everybody experiences side effects from ART. The HIV medication used today has fewer side effects and fewer people experience them, and they are less severe than in the past. Like about 30 years ago, there were tons of side effects and obviously more medication that people needed to be taking per day. So side effects can differ from each type of antiretroviral therapy medication and from person to person. Some side effects can occur once you start the medication and may only last for a few days or weeks. Other side effects can start later and last longer. The use of antiretroviral medication, if we are looking into race and ethnicity disparities again, minority groups generally associated with antiretroviral therapy non-adherence in the US. We will talk about various down the road, but fewer Blacks living with HIV infection has sustained these viral suppressors compared with Hispanic and whites. We need a collaboration among providers, CBOs, and state and local health departments to strengthen programs that address the barriers to HIV care. There are many. The antiretroviral therapy prescriptions to prescribe the most appropriate for the patient or the person, to work on medication adherence. And we're going to see down the road, like New York City, and how they have tried to work with all of these issues in HIV epidemic, and sustain viral suppression among Blacks. This could be very beneficial, eliminating racial, ethnic disparities in HIV. If we look into the HIV continuum of care by sex in the US, I know that this is 2014, we haven't changed much. Here is important to highlight that when we are looking for the care continuum, the viral suppression here, it's the yellow gold color. And we can see that even though we are progressing in diagnosing people, like for men, 84%, in women, 88%, the viral suppression for men is pretty much 49%, and for women, 48%. So something needs to be done to really increase access to medication, so viral suppression could be really higher. Let's talk about the New York status neutral navigation, because they are doing a good job trying to address the issue of HIV in the more concrete form, or new form. So what's status neutral navigation? That was one of the questions I put over there, and probably if you want to use the chat room and tell us about your ideas, or what you think it is, or what do you know it is. And the second question that I would like for you to give us some comments on is, can status neutral navigation improve outcomes? How? And then are HIV positive patients targeted by status neutral navigation? Or are the HIV negative patients the ones targeted by status neutral navigation? Take a couple of seconds and let us know what are your ideas or knowledge about this topic. I want to be going a little bit to the history of status neutral navigation, so we are on the same page. HIV epidemic has evolved over the past 3 decades. I know that some of you were not even being born when we start with that particular fight. HIV continued to spread. We have 37 new diagnoses in the US in 2016. And we have more than 1 million people living with HIV in the US, 1.1 million. It's a large number. Given these staggering numbers, adopting new approaches and paradigms for the prevention in treatment and messaging and programming was critical. The status neutral builds on earlier innovative HIV prevention and care continuum, following the original care continuum proposed by Gardner. This is how it looks. So what we're trying to do with the status neutral continuum is to have two pathways, but keep working with positive as much as with negative people. So for positive, we go to the regular treatment and retention and care and viral suppression. But for the negative, we have the other pathway that in some point, we go them and repeat the test. So meaning that we're taking of both type of groups without any doubts, they can be part of the same system. So what is the status neutral navigation? This is a novel schematic that incorporates both HIV positive and negative people at risk, making that just status neutral. We are not talking about if you're the positive or negative status. It proposes the same approach for engagement regardless of one's HIV status. This multi-dimensional continuum begins with an HIV test and offers two divergent paths depending on the results. These paths end on a common final stage. And the question, again, for you to type some of your comments or answers, could your organization implement status neutral today? If yes, why yes? And what would be needed if you say no? What do you think are the gaps or what is needed? A couple of seconds and try to make your comments on the chat room. Well, the status neutral navigation, the key characteristics is that it's not linearity. It's not like you come in, I'm giving you, you're gone. It's a continued prevention, quality of care services as part of an ongoing effort by patients and providers to maintain this engagement in clinical preventive care or treatment. The endpoint is not a final state, but a dynamic one requiring continued attention by all parties. Emphasize the consistent return among the uninfected to the HIV testing with the result trajectory into and through the continuum as appropriate depending on test results. So it's neutral. It doesn't matter if positive or negative were part of the system. New York status neutral navigation. The New York City Health Department has developed this kind of city HIV status neutral prevention and treatment and highlight several key messages that are not included in the traditional HIV Care Continuum. This new paradigm outlines the steps that can lead to an undetectable viral load and steps for effective HIV prevention, such as using of condoms and taking pre-exposure prophylaxis and actually known as PrEP. New York status neutral has kind of pioneered that services using the status neutral philosophy as a status neutral approach to the HIV care means that all people, regardless of the HIV status, are treated in the same way. All starts just with the simple HIV test. Any results, either positive or negative, kick off the engagement with the healthcare system, leading to a common final goal where HIV is neither acquired nor passed. And you can see here how it doesn't really matter if the test result is going to be positive or negative. the person becomes part of a system. And if he was negative in some point into that patient engagement, it will go back to a diagnosis. So we hope that the diagnosis will continue being negative, but if for some reason it becomes positive, then the person goes to the positive test cycle, which engage on treatment, and we're trying to reach viral suppression, which is the main goal. So the status neutral model, a person is diagnosed with HIV, so that person is linked to treatment, engagement, and treatment can start the same day. They are continuously provided with a high quality care and keep them with an undetectable viral load. They will not pass HIV through sex because viral load will be undetectable. Or a person test is negative. So they are linked with prevention engagement sites. So some people will start a pre-exposure prophylaxis or post-exposure prophylaxis. Other group will ongoing testing for HIV and other STIs. And the engage will continue providing them with the tools so they can remain HIV negative. New York status neutral, using a strategy like this require the attention to planning and follow-up with all the patients. It also involves efforts to reach and engage people who are at high risk of HIV. In New York City, the Department of Health has been a huge champion on this strategy. They transformed the public STI clinics into sexual health clinics that act as gateways into HIV prevention and treatment programs. New York City had a record low numbers of HIV diagnoses in 2017, down about 35% since 2013, when the concept of status neutral was first introduced. Status neutral resonates with community advocates who feel it has a great potential to provide better care for people living with or at risk for HIV infection. This balanced approach of linking clients to ongoing services can help normalize routine testing and offer care options for both HIV positive and HIV negative people in a destigmatizing way. Continue with the New York status neutral. For this concept to work, we must have certain measures in place. So promotion of the status neutral continuum of care depends on the strong partnership and the integration of services. We need to ensure that both the preventive engagement and the treatment engagement pathways have as few barriers as possible for clients to navigate. When done effectively, rapidly, linking new people with HIV treatment and those who are negative to ongoing prevention programs will help us to dramatically reduce the new HIV infections, support positive people to thrive beyond HIV, and reduce health disparities where they continue to exist, and obviously reduce HIV stigma. So that is kind of a summary of whatever we were presenting. It's a very important way of start looking into HIV infection with a different view. And so we can say that in the context of these goals and new tools, we are looking for stimulate and guide actions and measures that take us to better outcomes. The synergies and dynamism inherent in the new status neutral continuum help using us closer to our critical goals. So that is what we'd like to achieve. the virtual eliminating new HIV infections, that is probably the goal, effectively supporting people with HIV to live long and healthy lives, and eliminating the disparities that persist among some populations. Status neutral, people at risk of HIV exposure taking daily pre-exposure prophylaxis, and people with HIV with sustained viral load suppression do not acquire or transmit HIV. So the HIV divide ends here. Thank you for your attention. So let's go to the questions that you have posted. Thanks again.